Hello, everyone. My name is Fareed Luis, and the formula I chose was Zi Ren Wan, or Hemp Seed Pill. So, what is Zi Ren Wan? It's a classical formula that moistens the intestines, drains heat, unblocks the bowels, and moves qi. It's comprised of Homa Ren, which moistens the intestines, Da Huang, which purges heat and drains stagnation, Bai Xiao, which nourishes yin fluids, Xing Ren, which descends lung qi and moistens, and Zhe Shi, which moves qi and breaks up stagnation, and finally Hopo, which moves qi and relieves fullness. So most documented drug herb interactions trace to Da Huang and Bai Xiao. So the first interaction, which is labeled moderate, it's a Da Huang plus anticoagulants. So the mechanism of that interaction is actually twofold. So there's a pharmacokinetic and a pharmacodynamic. The first one is Da Huang's laxative actions, accelerates GI transit and can cause diarrhea, which paradoxically may increase warfarin absorption and raise INR. The pharmacodynamic is Da Huang has an independent blood moving mild anticoagulant activity, producing an additive bleeding risk with anticoagulant drugs. Moving on to clinical significance. So the likelihood is probable. So warfarin has an exceptionally narrow therapeutic index. So the target INR is 2.0 to 3.5, making it one of the most studied herb interaction drugs. The population at risk are patients on long-term anticoagulation for AFib, mechanical valves, DVT-PE, or recurrent stroke prevention. As we move on to the severity, potentially life-threatening hemorrhage if INR raises uncontrolled. With respect to management, check INR within 3 to 5 days of stopping Zi Ren Wan, then per routine schedule. Counsel patients to report bruising, bleeding gums, dark stool immediately, and avoid combination with other stimulant laxatives to limit the additive GI bleeding effects. The next interaction, or the second interaction, I should say, is Da Huang plus diuretics and digoxin, and that's labeled high. The mechanism of interaction is Da Huang anthraquinone driven purgative's laxative action promotes GI potassium loss, similar to the pharmaceutical stimulant laxatives. So combined with potassium wasting diuretics, this creates a double potassium hit, and resulting hypokalemia sensitizes the myocardium to the toxicity. The clinical significance, the likelihood, possible to probable in patients with pre-existing renal cardiac disease, poor diet, or elderly patients prone to electrolyte shifts. The population at risk are heart failure patients on loop thiazide, diuretic plus dioxin, a very common combination in geriatric cardiology. Severity, hypokalemia, induced cardiac arrhythmias, duodoxin, toxicity, can precipitate life-threatening dysrhythmias. Management, obtain baseline serum potassium before initiating, and then recheck within 1 to 2 weeks. Watch for dioxin toxicity signs like nausea, visual changes, arrhythmias, confusions. And consider potassium-sparing alternatives or dietary potassium counseling if formula is continued long-term. The third interaction is Da Huang plus hepatotoxic drugs. Mechanism of interaction. So Da Huang anthraquinones compounds have documented hepatotoxic potential in animal models and human case reports. Approximately 24 cases or documents liver injury cases. Combined with other hepatotoxic agents, the additive burden on hepatocytes raises liver injury risk, especially with prolonged use. Clinical significance. The likelihood. Theoretical to possible. Rhubarb is also documented as having a hepatoprotective two-way effect at typical short-term dosage. Risk rises with prolonged high dose use. The population at risk. Patients on chronic statin therapy or frequent acetaminophen use for chronic pain. As we move on to the severity, drug-induced liver injury to rarely acute liver failure with prolonged high-dose exposure. With regards to management, obtain a baseline LFTs before starting in patients already on statins, limit formula duration, reassess need for continued use beyond 1 or 2 weeks, and educate patient on signs of liver injury, right upper quadrant pain, jaundice, dark urine, bursitis. The fourth interaction is Bai-Shao plus anticoagulants and antidiuretics. Antidiabetics. And this is labeled low to moderate. The mechanism of interaction, anticoagulants. Bai-Shao contains catechins and ethyl glycol with demonstrated anti-platelet aggregation activity. Pharmacodynamic, additive bleeding risk. The anti-diabetic portion, or I guess section, is the mechanism not fully characterized, but documented synergistic hypoglycemic potential with insulin. The clinical significance, the likelihood, theoretical, possible, described as a mild anticoagulant effect in clinical herb references. It's a lower confidence evidence than Da-Huang interactions, which we looked at earlier. The population at risk is diabetic patients or insulin, patients on dual antiplatelet therapy. As we move on to the severity, it's mild to moderate bruising and bleeding, mild to moderate hypoglycemic episodes, rarely severe in isolation, but additive with Da-Huang effects above. Management. Counsel diabetic patients to monitor blood glucose more frequently when starting the formula, combined with anticoagulant monitoring already in place for Da-Huang's interaction, the one we saw up above, interaction 1. And then no dose separation needed. This is a pharmacodynamic, not absorption-based. This next slide, I essentially just created a summary table that just kind of lists everything I just went over. As you can notice, the first 3 are Da-Huang, and then the last one is Bai-Shao. One key note here is the general timing principle. For absorption-based, the pharmacokinetic interactions separate Zi Ren Wan administration from the interacting medication by at least 1 to 2 hours before or 2 to 4 hours after dosing. With respect to pharmacodynamic interactions, like additive bleeding and additive hypokalemia, timing separation does not eliminate the risk. Clinical monitoring is required instead. Clinical takeaways. Screen before prescribing, so always obtain a complete medication list. Da-Huang is the primary driver. Coordinate with the prescriber and limit duration of use. And here are my references.